So firstly, I want to ask Dr. Stone the first question. The publication of a result of ischemia trial has caused heated debate. What treatment strategy should be adapted for the patient with the stable coronary heart disease with the symptoms? Could you share your opinion, Dr. Stone?
Yes, thank you very much. The ischemia trial was a very complex undertaking, and the results of the trial have to be considered very carefully. I think it's much more complex than to just say the trial was positive or the trial was negative. So overall, when one looks at the number of events that occurred at a median 3.2-year follow-up among the 5,179 randomized patients with stable coronary artery disease and moderate or severe ischemia, there was no overall major difference in the number of hard MACE events. And that was cardiovascular death, myocardial infarction, or hospitalization for unstable angina, heart failure, or cardiac arrest. However, the curves crossed, where early on there were slightly more events in the invasive arm, that is, patients undergoing angiography followed by PCI or CABG, and mostly because of periprocedural myocardial infarctions. But then with long-term follow-up, there were actually fewer myocardial infarctions in that group. So the curves crossed at about 2 years, and at the end of 4 years, there were actually slightly fewer events in the invasive arm. Now, if you look overall, you would rather have an event later rather than early if you're going to have an adverse event. So when you look at the overall time at which the average patient was free from event, it was similar between the two groups. But there was a difference in this trade-off of slightly more adverse periprocedural events in the invasive arm, but a better long-term prognosis in patients who were revascularized. Now, the second major part of this study was quality of life. And we measured quality of life with the Seattle Angina Questionnaire, and quality of life was clearly better in patients who went to the cath lab and then were revascularized. So it's important to note that we actually only enrolled patients with no symptoms or mild symptoms in this trial. There were only 4% of the patients had class 3 or 4 angina. Most patients were having either monthly angina or no angina. And that was done intentionally to make sure that the patients wouldn't cross over and have revascularization for symptoms. Despite the fact that the patients were having so few symptoms at baseline, during follow-up, they clearly felt better. They had a better quality of life with the invasive approach. And if you looked at the percentage of patients who were angina-free, it was substantially higher in the invasively treated patients during follow-up, all the way through 4 years or longer, compared to the conservative approach. However, the final point is that the extent of the benefit in terms of improvement in quality of life really varied according to the symptoms at baseline. The more symptomatic the patients were at baseline, the better their quality of life was with the invasive approach. So if they were having any angina at baseline, even a couple times a month, let alone weekly or daily, they felt better with revascularization. However, if the patients had silent ischemia, that is no symptoms at baseline, but they were just enrolled in the trial, and that was almost a third of the patients, then you can't make people who are having no symptoms feel better long-term. So they basically felt very similar with an invasive approach compared to a conservative approach. So overall, I believe, in my own opinion, this trial was on the positive side for an invasive approach. There tended to be fewer long-term events with the invasive approach, not statistically significantly different, but there tended to be fewer events. And the patients who were having any symptoms at baseline clearly felt better. But importantly, the last thing I'll say is that there was absolutely no difference in mortality. And despite the fact that we enrolled mostly patients with moderate and severe ischemia, these patients still had a very low mortality rate, only about 1.5% per year. And even though you can see they've got the whole anterior wall is ischemic, or even more extensive ischemia than that, they weren't dropping dead. And the mortality curves were superimposable. So there's no rush to revascularize these patients. So I believe you can talk to the patients and find out their own preferences. If you've got a patient who strongly wishes to avoid any procedures, even an angiogram, then you could consider medical therapy. Presuming they've got coronary artery disease, you should have a CAT scan first, though, to rule out left main disease. That's a very important point. We excluded left main disease in these patients with a blinded CT scan before they were allowed to be enrolled, and almost 10% of the patients had left main disease who had moderate to severe ischemia. So as long as you've undergone a non-invasive CAT scan, CT scan, to rule out left main disease, then the patients could be managed without an angiogram on medical therapy and reserved for the cath lab if they have breakthrough symptoms or a myocardial infarction or other adverse events. On the other hand, if you have a patient who's having angina at baseline and would really like to feel better faster, then, and they don't want to take medications, for example, they don't like the side effects from medications, then they could go right to the cath lab for angiography and then referral to either PCI or bypass surgery, depending on the extent of the disease. And overall, they'll, have more rapid resolution of symptoms and fewer long-term symptoms with that approach.
Okay, thank you. The second question is with the intravascular ultrasound IVUS, coronary fraction fluid reserve FFR, and optical coherence tomography OCT has been used in the decision making in the interventional treatment of the stable coronary heart disease. Would you please introduce us with the guiding value in the evaluation of the lesions? Please.
Yes. Well, it's once you decide that you're going to treat the patient with PCI, you have to make sure that you treat the right lesions. And we know that FFR and IFR and QFR and other physiologic approaches that you can apply in the cath lab are very accurate for determining which lesions are ischemia-producing lesions and therefore are most likely associated with symptoms. So you should use physiologic lesion assessment on any intermediate stenoses, any that are, say, visually less than 80% severe, to determine which ones should undergo revascularization, at least with PCI. We also know it's very important that once you decide which lesions to treat, you should get an optimal result. Stent implantation needs to be meticulous, and the results, even with contemporary stents, vary with the minimal stent area achieved and making sure you're treating all the significant disease and you're not leaving any residual untreated disease at the edges or any untreated dissections, which, at least major dissections, which you can't see very well by the angiogram. So we strongly believe that in most cases of PCI, all except for the very simple cases, should undergo guidance with either intravascular ultrasound or optical coherence tomography to ensure an optimal stent implantation result. Finally, I'll say that there's also some evidence that the prognosis depends on physiology post-procedure. So if you've normalized the IFR or the FFR, and we're starting to do large-scale randomized trials to see if doing that routine measurement of physiology after stenting to either look for focal stent issues or distal disease or more diffuse disease or untreated disease will then lead to improved outcomes in those patients.
Okay, thank you. The third question is, in the ischemia trial, the invasive treatment improved the progresses of patients with angina than the conservative treatment in some extent, but the benefit was limited to 65% of patients who had angina within 1 month before the group. So what's your opinion about this result, please?
Yeah, excellent point, and you're absolutely correct. The benefit in terms of improved quality of life and improved symptom control in terms of becoming angina-free were limited to the patients who were symptomatic on the Seattle Angina Questionnaire, which was taken within 4 weeks, which reflects 4 weeks prior to treatment. And in the ischemia trial, approximately a third of the patients, 35%, like you mentioned, had no symptoms within 4 weeks. And those patients, while some of them developed symptoms during time, they didn't have a major difference in whether or not they developed angina over time or what their quality of life was with the invasive approach versus the conservative approach. There were some slight trends that they did a little bit better with the invasive approach, actually, even if they were asymptomatic in baseline in terms of quality of life, but not statistically significant. On the other hand, if patients were having daily or weekly angina or monthly angina, even a couple times a month, just a few episodes of 5 minutes of angina, then they were likely to have more and more angina over time, and their likelihood of experiencing a substantial quality of life benefit and becoming angina-free was much better if they had the invasive approach. For example, the number needed to treat for symptomatic patients was approximately 3 to 4. For every 3 to 4 patients you would treat, you would, with the invasive approach compared to the conservative approach, you would make 1 patient angina-free. And that's a very low number needed to treat, so it's a very good therapy.
Okay, thank you, Dr. Stone. Frankly speaking, initially, when I look at the result of ischemic trial, it reminds me about another clinical trial, maybe about 15 years ago. It's the Courage trial, Courage study. It's also involved patients with stable coronary artery disease and shows that the intervention comparing with optimal medical therapy cannot improve the survival of the patient. Ischemia has a quite similar result, but the difference is the ischemia trial involved the patient with maybe moderate even to severe territory of myocardium has ischemia. But I remembered there is a small subgroup study, the MPF subgroup of Courage trial demonstrates for patients with greater than 10% myocardium ischemia, or if you can decrease the ischemic territory more than 5%, you can see the mortality improvement in this kind of patient. Are there any similar subgroup study in ischemic trial? Because we know the patient has more than 10% territory of ischemia, but how about post-procedure? After the revascularization, to which extent the patient ischemia was improved? Are there any information about this regarding the interventional group patient?
That's a great question. And there were, you're absolutely correct. The results of ischemia and Courage were in many ways similar. But I will say there were a few differences between Courage and ischemia important to understand. Of course, ischemia was testing a strategy of angiography with PCI or cabbage versus medical therapy, versus Courage, in which all the patients were enrolled after angiography, and then it was just a randomization of PCI versus medical therapy. Courage was done in an earlier era where most of the patients under the PCI treatment were treated with bare metal stents, where here we used mostly contemporary second-generation drug-eluting stents. And then you mentioned the third big difference is that ischemia required moderate or severe ischemia, where moderate or severe ischemia was included in a minority of patients in the Courage trial, because most of those patients, the people would not randomize back then. So when we look at the differences from Courage to ischemia, there again was no overall difference in death or myocardial infarction. But we did see in ischemia that late myocardial infarctions were clearly reduced. And that's an important observation because those are the myocardial infarctions that tend to affect mortality, more so than the procedural myocardial infarctions. And we've proven very clearly now in ischemia that late MIs are reduced. Second, the benefits in terms of being angina-free, which were present in Courage, were even more notable in ischemia. In Courage, the increase in being angina-free with PCI was lost by 3 years. In courage, it extended to 4 years, and I'm sorry, in ischemia, it extended to 4 years and beyond. And that probably reflects, one, the use of good drug-eluting stents in ischemia compared to bare metal stents in courage, and two, the fact that some of the worst patients had surgery in ischemia where no patients had surgery in courage. Finally, to get directly to your question, we don't have any post-procedure ischemia testing in the ischemia trial. However, we're going to importantly be looking at the outcomes of the trial according to, in the invasive arm, whether or not the operator was able to achieve complete revascularization. And we're doing a very detailed study of all the invasive patients according to both anatomic and functional or ischemic completeness of revascularization. And we've not yet finished that analysis. We're hoping to present it at TCT this year as a late-breaking trial. And so that will at least partially address your question as to if we can at least relieve most of the ischemia, but with revascularization, for example, by opening up all the chronic total occlusions to viable myocardium. Will that lead to better outcomes? And again, hopefully we'll present those data at TCT.
Okay, thank you, Dr. Stone. As we, how do you think the ischemic trial will change our future guidelines in the treatment of patients with stable angina?
It's hard to say how much it will affect the guidelines. It should affect the guidelines. I think it will affect it in subtle ways. Basically, ischemia provides support for both approaches. Since there's absolutely no difference in mortality, okay, it provides support for physicians and patients who want to wait and don't want to undergo upfront angiography or intervention. As long as I mentioned, they have a CTA to exclude left main disease, and these have to be selected patients with no heart failure and with manageable symptoms at baseline. So basically, class 0 to 2 symptoms at baseline. On the other hand, there's also a lot in ischemia to recommend an early invasive approach in those patients. Even the patients with mild symptoms, very stable disease, benefited in terms of quality of life. And so Dr. Eugene Brunwald and Elliot Antman in their editorial wrote that there's a lot to recommend in ischemia for an early invasive strategy. You don't have to wait to see if the patient is failing medical therapy, that is having breakthrough symptoms or intolerable side effects to their drugs. Even early on, before you try 2 or 3 anti-anginal drugs, if the patient's having, moderate symptoms, suspected coronary disease, then you could go right to angiography and revascularization is appropriate, and you will at least improve that patient's quality of life. So we'll see how the guidelines react to the data. That'll probably take several years, but these are the practical implications for caring for your patients.
Okay, and one more practical question is, say, if the doctor to do the stent, he can explain to the patient, this stent can help you to improve your symptoms. But on the other hand, some doctors or some patients, they don't like the stent. They think, okay, we can just wait. So as an interventional cardiologist, how do we make our decision in the future, or how do we try to explain to our colleagues or to our patient, he or she should have the stent?
Yes. So first of all, ischemia applies to a very small group of patients. These are patients with stable coronary disease, with no heart failure, nearly normal left ventricular function, who have had an CT angiogram to rule out left main disease. Okay, so very important. Those patients, I think you should talk to the patient. And by placing a stent in those patients, you will not make the patient live longer. We've not found a subset yet in which patients will live longer. So you're primarily treating those patients for symptom control, and therefore you have to talk to the patient. And those patients who don't wish a stent, you could say, okay, we'll manage you with medications for now. And if you have breakthrough symptoms or you can't tolerate your medications, then we can always do the catheterization and stent later. On the other hand, the patients up front who want more rapid and more complete symptom control, you could offer angiography and revascularization up front. Now, again, very importantly, patients who have acute coronary syndrome, STEMI or non-ST segment elevation ACS, we know that stents save lives and reduce rates of myocardial infarction. So you have to strongly encourage those patients because they're very different. Patients with heart failure, okay, from the STITCH trial and other registries, live longer with complete revascularization. So heart failure patients with extensive coronary disease, patients with left main coronary artery disease, those patients need revascularization. So there you can strongly tell the patient the stent may save your life and therefore you should undergo angiography and revascularization.
Okay, thank you.
Thank you, Dr. Stone. Could you give us the final remarks about ischemia trial and what's the conclusion can influence the physician of daily practice, please?
Well, thank you. So I think ischemia was a very important study because as the largest and most thorough study of its kind to date, and again, the first using contemporary therapies, both good drug-eluting stents, ischemia guidelines, and of course, good bypass surgery techniques, it has really refined our knowledge how to best treat coronary disease. We did definitely learn from ischemia that you will not make patients live longer. If you treat patients without left main disease, with stable symptoms, without heart failure, without acute coronary syndromes, and only asymptomatic or mild symptoms, you will not make them live longer. However, you can make them feel better if they're having even very mild symptoms at baseline. Only 1 or 2 episodes of angina a month, they'll have a better quality of life with revascularization. And if they have, daily or weekly angina, the differences are even more profound. Again, this ischemia is a strategy of whether or not you even go to the cath lab to define the coronary anatomy and then make a revascularization decision with either PCI or bypass surgery, depending on how complex the anatomy is, versus not even going to the cath lab. So for eligible patients, very important, you have to take your patient's preferences into account. This is not a situation where the physician should beat their chest and say, I know what's best for you, okay? Unlike, let's say, STEMI. We know what is best for a STEMI patient. They should go to the cath lab and get a primary PCI. The patient with left main disease should have either surgery or PCI for left main disease. But for these types of patients, you have to listen to the patient and respect their wishes in terms of procedures, more rapid symptom relief, versus the desire to try medications first. And ischemia has taught us that that's a very safe approach.
Okay, thank you. How time flies. Through the interpretation and discussion of this trial, we have a deeper understanding of the trial and also provide important guidance for the physician on how to choose treatment strategy for such patient. So looking forward for more research evidence in the future to optimize treatment. Thank you, Dr. Stone, Dr. Li, to join us. See you next time. Thank you.
Thank you. My pleasure.
Okay, thank you.
Thank you very much.
Okay.